Now I'm pleased to welcome to the stage Dr. Marissa Levine, Commissioner of Health for the Commonwealth of Virginia. I won't read her bio, it's in your folders. You will be tested at the end of this conference. Immediately following Dr. Levine's presentation, we will have time for a few questions from the audience. I'd like to ask that when you are called on, please give your name and organization. We'll have people in the room with microphones since we are taping this. So please wait for the mics and then give your name and organization after Marissa calls me. Thank you.
Thank you, Pat, and congratulations on 10 years. Good morning, buenos dias, shalom. I know there are about 120 languages spoken in Northern Virginia, but I'm not going to do them all. So I'm really pleased to be here with you today, and as soon as I find my presentation, I will get started. So how many of you have had the pleasure of hearing me speak? Okay. So for the rest of you, I'm a little bit of a troublemaker. And I think that's my real purpose here this morning, is to light a fire under the work that you do so that we can continue in the right direction. The focus today is upstream, but my focus is really about intentionality. And I think the issue, quite frankly, is that we have not been as intentional as we need to be to promote, design, and develop and deliver health and well-being to the people of Virginia and here, the people of Northern Virginia. What I'd like to do in my short time with you is discuss those factors, those upstream factors, which I think most of you are familiar with, and then review what we know about the health of this region, and I think it'll be a great prelude into Dr. Wolf's talk. Talk a little bit about the population health improvement focus, and also make sure that you're aware of our first state health improvement plan in a number of years, the Virginia Plan for Wellbeing. How many of you have seen that? Okay, so for the rest of you, it is online and the website is in the handout. How many of you are aware of the county health rankings from Robert Wood Johnson? Okay, many and most of you. So this is an effort here to look at those upstream factors. If you look at all the items in blue, that's really a focus on those social determinants of health. And for Virginia, we've utilized it to determine how one county ranks to another. And many of you have seen this, have seen the maps. This is on the factors with the more darkly shaded counties demonstrating areas where the impact on health is much more negative, much more significant in terms of negative outcomes. And I know many of you have seen this, but I'm going to ask of you in the northern region that as soon as you figure out how to intentionally design health, look south, because your partners in the southern tier of Virginia need your assistance. And I know many of you look elsewhere. You look at other countries in this hemisphere and others. There's incredible giving capability, but we need the brain power here to also work within Virginia. The issues are huge, not only here in Fairfax and other parts of Northern Virginia, but also in many other parts of the state. And as you know from the outcomes component for the county health rankings, we see the exact same patterns, such that we really have two Virginias. And that's not a good thing. Many of you have also seen a slide like this, which talks about those determinants that impact our longevity. And many of you who've looked at this know that our behavioral patterns, social circumstances are significant determinants of health, much more so than health care. And again, not that that's not important, but health care cannot be successful without determining and including these incredibly important impacts. And the issue is, for individuals, behaviors are contextual. They're the result of where you live, work, and play, period. So if we're really interested in the upstream factors, we have to look at what's going on where we live, work, and play. And many of you have seen the Tom Frieden pyramid, looking at the different components and their impact on population health. And I like to say with this slide that it's not that any one part matters, and it's not that any one part's less important. It gives you the impression that the clinical and counseling components at the top are less important. But the real take-home message here is that we can't be successful in those spheres unless we impact the foundational issues, the socioeconomic issues, and policy, which is such a huge driver. And I know we have some of our legislators here, and they know it's really critical in terms of determining outcomes. So we have some successes in those arenas, but we have a lot more work to do. And this is why. We rank in the middle. And I'm standing here with you in Northern Virginia, one of the most prosperous areas of the country, a state that is top 10 in per capita income, and we are in the middle in terms of health outcomes. Why is that? Who knows the answer? Not everybody has the same access. The opportunities to be healthy vary widely, and there are huge disparities. And you all know that. That's nothing new. What I'd like to do is challenge you, though. And this is the troublemaker part. So this is a slide. I took infant mortality data for the last 10 years that we have. It's up to 2013. We actually have some more recent years. But many of you have seen this data. On the top is the infant mortality rate for the African American community, and then many of the other populations along with the US rates. What strikes you about the trends over 10 years? Anything? Technically, there's really no change. There is some downward drift, but there is no change. At least no significant change. And we have a huge disparity facing us on infant mortality. We have work to do. So I'm going to ask the question, but I don't expect an answer. Why hasn't it changed? We have the data. We think we know where the issues are. We haven't dealt with the issues at the root of this. So here's a point for you to consider. Is it possible that perhaps we're part of the problem, including how we categorize and view the very data that we're looking to impact, or issues that we're looking to impact? Think about that for a minute. And then I want you to think about, and maybe you don't know, but I want you to think about vital records in Virginia, which is where a lot of this data comes from. So vital records is set up by categorizations. It's been in place for a decade, 100 years. And does anybody know what the root of those classifications was? I'm going to challenge you to read the history of vital records in Virginia and why we were categorizing the way we did. Perhaps the very categorization of that data is inhibiting us from dealing with the issues. And perhaps we need something different. And I think that's what today is all about. A different view, looking upstream, and looking where it really matters. And I will contend that this approach not only doesn't get the job done, but it labels groups of people in a way that others can use against them. Think about that for a moment. So we have, many of you know, we have attempted to look at ways of measuring the social determinants of health by considering place, where you live, where you work, and where you play. And these are the components, the 13 indices of the Health Opportunity Index. It's not perfect, but it's a start. You're going to see other ways of looking at social determinants. But I think it's been really powerful and impactful for helping us start to think differently. And I think that's really the key. If we look at Virginia by Health Opportunity Index, which we can get down to the census tract level, in this case, the shading is actually opposite of Robert Wood Johnson. So the southern tier is less shaded, and that means that people in the southern tier have less opportunity to be healthy than people in the northern parts of Virginia. But this is true. If I showed you Fairfax or Richmond, you would see it down to the census tract level. This is true everywhere in Virginia. So let's try something to look differently at the data. What if we took the Health Opportunity Index components as a spectrum, low opportunity, mid opportunity, and high, and begin to correlate it with outcomes that really matter to people? So first example, just at the state level, is we took the ambulatory sensitive conditions. These are issues that people technically shouldn't have to go to the hospital for, but in all likelihood, they don't have access to preventive care, or they don't have a health home, and so they end up in the hospital. And lo and behold, wouldn't you know, that people in the lowest health opportunity areas end up in the hospital more frequently with preventable conditions than people in the high opportunity areas. Okay, no big surprise there. If we look at it by condition, this is diabetes on the left and chronic obstructive pulmonary disease on the right, same thing holds. So again, this is not necessarily about race or subpopulations, ethnicities. This is about place. So this is what Northern Virginia looks like if you take the Health Opportunity Index. And in this case, we would put number of components to this from very low to very high, with very low being the dark blue shaded areas and very high being the dark green. And then we looked at, again, diabetes and COPD hospitalization rate, and we see the same correlations by place. So right here, where you sit, we have the exact same thing that we see at the big picture of the state of Virginia. Then we took out pieces of the Health Opportunity Index. This is the Townsend Material Deprivation Index, which identifies areas where people just don't have the same opportunity and access for the things many of us take for granted in our lives. And we looked at infant mortality, and lo and behold, those areas where the deprivation index is highest have the highest infant mortality. Where people are most deprived of the basic necessities of life, they have the highest infant mortality. Now, I'm not saying that's a direct cause, but I'm saying this is a different way to think about the issues. And here we took schooling. I know something that Dr. Wolf has been looking at, and we looked at it for prematurity, low birth weight, and we see the same correlation with this component of the Health Opportunity Index. So I hope this is getting you to think differently now, that maybe our focus has been misplaced. Maybe we have focused on groups of people by race and ethnicity, and intentionally or not, blaming them for the problem. And maybe, for those of you who are in local government, maybe the issue is more about how we design our communities physically and operationally. And the question is, could we be more intentional in how we do that if, at the end of the day, what we really want is health outcomes, or at least better health opportunity for everybody in our jurisdictions? How would we do that? Well, we thought about this a lot as we were working collaboratively at the state level on a state plan. And we thought about two foundational things. The first one is the concept that you have to redefine health. This is right up the Robert Wood Johnson alley of culture of health, that health isn't something that we just restore when we lose it. We want to retain and maintain it, and perhaps that's actually not only better for people, but it's less costly to society if we do it that way. And if you think that way, then you see opportunities in your communities in the non-healthcare arenas, such as walkability, how you design your communities to promote walking. And if you saw the recent Journal of the American Medical Association, there was a story, a report about walkability as a correlate to decreasing diabetes or impact from diabetes. very powerful, and a different way of thinking. We think foundationally building these healthy, connected communities is really critical because that's where the built environment influences behaviors. Obviously, we need clean air and clean water, as we saw in Flint, Michigan. And then this also is the arena where policies are made. Because a healthy, connected community makes the kind of policy that considers health and its impact at the beginning of the policy development process for any policy. Because all policies impact health in one way, shape, or form. So why not have them impact health positively? So a foundational aspect of a healthy, connected community, and then that community needs to assure so that we break the cycle of burden of disease that every child has a strong start, an opportunity to be healthy and get them on the better trajectory in life. If you take those two things with the redefinition of health, there is incredible opportunity. But the concern is that if you want to make evidence-based decisions, you have to be careful how you assess health in your communities. And I think we have a great opportunity now, and you're going to hear more from Dr. Wolf, by looking at issues of place and the geographic inequalities that exist, because that, I think, is where the opportunity in the 21st century comes from. So for those of you who are not familiar with the Plan for Wellbeing, I've just outlined the four major aims: the healthy, connected community, the strong start, the culture of health, preventive everywhere, preventive actions arm, and then creating a system of health care that is designed for people, not for payers and providers. It's designed for people. Because if we design it for people, it will be a system of health care. And that's how we get to well-being in Virginia, which, as you see, we have a lot of work to do. We have more data on our website. I put a plug in here about Zika, but that wasn't the intent. But Zika is about assuring a strong start for all our children. We don't want our children to be born with microcephaly or other birth defects. But there is data better available for you, and I look forward to working with you so that we collectively can become the healthiest state in the nation. Thank you very much.